Okay. So, good evening, everyone. This is another interesting webinar series of UPSOS, where there is a showcase of extremely wonderful videos from expert in their fields. And this time, the topic is dilemma to decision. That means they had some issues in a particular case, which was later solved very nicely. So we have wonderful experts today: Dr. Shobhit Chawla, Dr. Pradeep Mohanta, Dr. Aparajita Chaudhary, Dr. Lubhavni Diwan, and Dr. Nilesh Kumar. And we have expert panel for discussion also: Dr. R.K. Jaiswal, Dr. Anupma Upasni, Dr. R.N. Kushwaha, Dr. Pradeep, Dr. Amit Garg, Dr. Surbhi Dutt, Dr. Rajat Goel, and Dr. Namrata Patel. We are fortunate enough that Gurus of Guru Dr. R.N. Mishra sir has joined today, and his blessings are with us. First of all, I would request President sir to welcome the delegates, and then we will hear blessings from Dr. R.N. Mishra sir. Dr. Shashank sir.
Uh, I just congratulate Shalini. You have done a great job as Chairman Scientific Committee, and you are absolutely doing the same way as Abhishek did as a Chairman Scientific Committee. And Shashank,
Thank you, sir.
as a President, you are doing a great job, and I'm sure all the participants will make a wonderful show of the videos. My best wishes to all of them. And Shobit is there, so he will guide everybody. He's one of the brilliant ophthalmologists of the Uttar Pradesh. So my best wishes to all of you. The only request to everybody is this, that 3 or 4 days are left. Take seriously the voting for the election of the All India Ophthalmic Society. बड़े दिनों बाद यूपी से इतने लोग खड़े हो रहे हैं इलेक्शन में, तो मैं चाहता हूँ सब के सब जीतें. खूब कोशिश कीजिए कि वोटिंग ज्यादा से ज्यादा हो जाए, क्योंकि यूपी की प्रॉब्लम यही है कि वोटिंग बहुत बहुत खराब होती है. और सालों से हम देख रहे हैं यूपी की रिप्रेजेंटेशन बहुत कम होती है ऑल इंडिया में. तो अब के शशांक तुम्हारी चेयरमैनशिप में या प्रेसिडेंटशिप में खूब लोगों को वोट डलवाओ, ताकि मैक्सिमम लोग जीत सकें. और बाकी तो साल भर ये प्रोग्राम चलते ही रहेंगे, सारे लोग पार्टिसिपेंट रहेंगे. सबको बहुत बहुत हमारी शुभकामनाएं. ऑफ्थेल्मोलॉजी बहुत तेजी से आगे बढ़ रही है, आप लोग यूपी को आगे ले जा रहे हैं. आई एम श्योर शालिनी विल डू वंडरफुल जॉब फॉर दीज 3 years, एंड बेस्ट विशेस टू ऑल ऑफ यू. थैंक यू सो मच.
Thank you, sir. Thank you
Thank you,
so
sir.
much.
Thank you. Thank you. This is
I will
Mishra
request
sir,
Dr. Shashank sir to say.
Dr. Shobhit Chawla and speakers and audience. Uh, Today we are going to discuss on various topics in this webinar, and we are proud to have such high level speakers this webinar. So I welcome to all, and Dr. Sami to start. Thank you.
Okay, so today I have my co-moderator with me, Dr. Karan Bhatia. We all know he is Vice President of UC and very active academically. And so we will be together doing this webinar, Dr. Karan Bhatia and myself. So first talk is by Dr. Shobhit Chawla, sir. We know that he is stalwart retina surgeon and doing extremely wonderful surgeries every day. We have been learning so many things from him. So today he will be talking about conquering a difficult traumatic macular hole. I request Dr. Shobhit Chawla sir to kindly share his screen. Sir, you are muted. Dr. Shobhit sir, kindly switch on your microphone.
Hello?
Yes, sir. Now you're audible.
Yeah, but I'm trying to get to the screen
Okay.
fully. वो मैक्सिमाइज नहीं हो रही सडनली, आई डोंट नो व्हाई. Can you just give me a minute to... Yeah, now it's there. Can you see me? Hello?
Yes, sir. You have to share your screen, sir.
That's
Now
just what
screen
I'm
is shared.
doing.
Yes, now we can see it.
Yes, sir. So your video is at the bottom, right bottom, sir, next to the trash.
Yeah, I
Right
want
there.
to
Right
open
next
it.
to
No,
that.
that's why.
Yes, sir.
No, I know it is right at there, but why is not the full screen coming?
So you click on that, it'll then open this full screen. Right next to the trash, the QuickTime thing is there.
Now it is there.
Yes, sir. You click on that. Now it will come, sir. Now you click on the green button, sir. Of the it will make it full screen. Go to the center of the video. You click on the video.
I've got it.
Yes, sir. Yes, sir.
Okay, so I'm presenting an interesting case. Is the audio coming?
Yes, sir.
So this is a 32-year-old male who presented with a history of tennis ball injury to the right eye. And he had a traumatic macular hole with a choroidal tear, as you'll see. So because traumatic macular holes are a tissue defect and not a dehiscence, so instead of an ILM peel flap, we planned this surgery of doing an autologous retinal graft, where we chose a site just outside the inferior arcade, which was ergonomically easy to approach, did some laser around it, raised it with an injection with a 41 gauge needle of the RL, which we normally use for VR surgery. And the trick is that to get the correct orientation of the graft, you leave it attached at one point till you have not decided to relocate it with your PFCL injection. And then you bring it underneath, then you make the last snip, so use a chandelier, and then you manually unroll it on top of the hole. The patient's visual acuity was 660 with no improvement before the surgery. He was very keen, and I removed the PFCL and I put in silicone oil. Next day post-op vision was 624 around day 1 to day 2, and then around 1 month post-op the vision was 618, and we did an early silicone oil removal because there was no detachment which we had done in this eye. So 1 month silicone oil removal allowed me to keep his lens clear also. So it's open for discussion. Hello.
That was a wonderful case, sir.
And in fact, I want to tell you one more thing. This hole was not there when I first saw the patient.
Okay.
This was his second surgery. The first surgery was a huge hemorrhage, sub-ILM hemorrhage at the posterior pole and some subretinal blood, for which it was huge, more than 1,500 microns. So at that time, about 3 months before this, I had put in tissue plasminogen activator, and this hole was not present even in the post-op period. This hole developed subsequently in this patient. That particular part was too large to show, in this small video.
Right. So I would request Dr. Anupama Upasni, who is a senior retina consultant from Indraprastha Apollo Hospital, Noida, to kindly.
Very nicely depicted surgery. Since this was a complicated, you went with an immediate surgery. I would just like to ask, is there any threshold for a simple macular hole, traumatic macular hole? They are spontaneously healing also sometimes.
Yeah. We
Any
never
threshold
operate
for
them
that
for at
or-
least 6 weeks to 8 weeks. We watch where it is going.
Yeah, and one more thing which I would like to highlight is the patient counseling in such cases is also very important because the functional and the anatomical recovery usually does not correspond.
I was
So,
lucky in this case, and
yeah,
here the
you
patient was keen, very
yeah,
keen to have the surgery.
yeah. So counseling is one thing which is
Yeah,
very important.
very. This surgery should only be offered when the patient asks for it
Mm.
after knowing the pros and cons.
So, any other expert panelist would like to comment?
To know the maximum regain of vision in such cases where the tissue has been taken from somewhere else. Is it 618, around 618, or it can be even more?
Well, in my cases, this was my fourth case of such a traumatic macular hole with this kind of a patching, fourth or fifth case. It has been around this level, though Professor Hassan Mortada has presented even 6-9 visual acuities.
Okay, sir.
And so has Barbara Parolini. In fact, the what incited me to do this procedure have been their results. Previously, I used to just flap these patients nicely with a cauliflower flap and at the most put a little bit of autologous serum which I have decanted in a syringe. And the hole used to close like a secondary that thing. It never used to be such a beautiful closure. And visual acuities used to be fair, but frankly speaking, both the procedure can be can be, case and match control study should be done to see is a autologous graft worth it. But the trend all over the world and especially in the European countries has been, the Mediterranean countries, I would say, has been to do a graft. And that's what's incited me to do it always.
Sir,
Switch
can
from
I
that
quickly,
technique to this.
sir, can I quickly ask you two questions?
Yes,
So,
please.
I'm nowhere close to doing any of these cases, but I'm basically quite intrigued. The autologous serum which you used, did you use it along with any fibrin glue to attach that part, sir?
No, no, no. I
You
just
didn't do any of
put
that.
in
You
a
just taken
drop.
the graft and put it there?
Yeah, yeah. If no, I
Uh,
have not used with the graft. With this
oh,
graft, I have
okay.
used nothing.
Oh, so
With this
how
graft, it's
does it
only
attach,
sip.
sir?
Before I was doing grafts, I used to flap these cases and put in one drop of autologous serum. Just
Oh, so so currently in this case, how did you attach it, sir?
attach what? The graft.
The
I
graft.
just left it under PFCL for some time and it
Okay,
stuck.
okay.
And then after that, I gently removed the PFCL with the air fluid exchange. And
Oh,
then I put in
nice.
the
Okay.
silicone oil.
Oh, so the PFCL takes care of the attachment.
Yes, you leave it for about 5-6 minutes.
That's
That's good.
amazing, sir. That's very, very nice.
You don't have to do any other, it just sticks the graft.
That's really great.
Actually, Survi, there's a difference between the corneal grafts and this because retina is vascular, so you don't need
Yes,
any
ma'am.
serum and
Yeah.
all.
Yeah, so we use all the glues and all for cornea grafts, but here it was like very quite intriguing to see that it's
No,
attached
no,
just with
this is the
PFCL.
standard procedure, just sticks.
So thank you so much, sir, Shobit sir, for this wonderful video.
Thank
Lots
you,
of
Karan.
learning points for everybody, and thank you for the panelists. Now moving on to our next speaker, the one and only Dr. Pradeep Mohanta. We have all learned from him. All learned FECO also from from seeing his videos. Uh, he started a group also, Eye Surgeries Worldwide, which we were all part of and learned so much from sir. So he did his MBBS from Calcutta Medical College and MS Ophthalmology from PGI Chandigarh. After that, he did his fellowship in Vittoretina from Shankar Netralaya, Chennai. He is a member also of the scientific committee of AIOS. And from a humble beginning in a rented place, Dr. Mohanta is the founder of Netra Jyoti Eye Hospital at Ranaghat, where he has trained many young eye surgeons. He is a comprehensive cataract surgeon and teaches both SICS and FECO to his trainees. And I must tell you, you must take a look at his YouTube channel. If you've not, you've missed something in life as an ophthalmologist. He has trained about 100 international candidates and innumerable national candidates. He has uploaded about 2,500 surgical videos on the channel I just mentioned. And the main mission of Dr. Mahanta, the legendary Dr. Mahanta, is to make good eye surgeons so that millions of patients get good vision through competent hands. So over to you, Mohanta sir. He will be speaking on, he will be basically showing a beautiful video on a traumatic cataract with primary PC rupture. Over to you, sir. Pradeep sir. So you're on mute, sir. Yes, sir.
Can you hear me now?
Yes, sir. We can hear you now.
So, this is a 12-year-old boy with a traumatic cataract. There is only anterior capsule is intact. The posterior capsule is ruptured. How do we know that? The antechamber is deep. Antechamber is not shallow. The cataract looks intumescent, but the anterior chamber is deep. So before entering into the anterior chamber, I'm making a pars plana entry first. With
Your video is not visible. If you're not sharing the video, we can't see your video right now. We can just see your browser view with so many videos. I think you can, sir, stop sharing and then you can again share so that we can see the video.
Yes.
Yes, sir. Now we can see the video, sir.
Okay.
So you can start from the beginning. Yes, sir.
So this is a traumatic cataract. The antechamber is deep. The posterior capsule is ruptured primarily because of trauma. There is first I am doing a pars plana entry for antivitrectomy because I'm sure it will be needed. And this is the pars plana entry. I close the sclerotomy with suture. This is 10 nylon, 10 9 nylon suture. And now we have to enter into the anterior chamber. This is just behind the limbus, a 2.8 millimeter entry. I'm doing capsulorhexis about 5 millimeters so that I can place a lens in the sulcus with optic capture. So this is the capsulorhexis. Thinking that it's not measured, but trying to make it about 5 millimeter, and it happened. Now, as I aspirate the cortex, the rupture appears and the vitreous tends to come out. Vitreous tends to prolapse. So I stop here, go through the pars plana. The irrigation is from the limbal root, and cutter goes through pars plana and do the antivitrectomy, and the lens matter also gets removed. A lot of lens matter gets removed by this pars plana antivitrectomy. And after that, we have to remove we can go to, I went to IA mode, IA cut mode, and removed some part of cortex. And rest of the cortex was removed by a 23G Simcoe cannula. When I was trying to remove the cortex by the cutter, it was tending to drop. So I shifted to Simcoe. Then I placed the lens in the sulcus. This is hydroimplantation of multi-base lens. My assistant is screwing the piston. I'm just holding the injector. It is done, and now the lens is placed in the sulcus. Why I did hydroimplantation? It is because if I use viscoelastic substance, most of it will go into the vitreous cavity. That is the idea, not to use viscoelastic substance. And then hydroimplantation was done. There was no vitreous. It was checked by triamcinolone and acetate. All the wounds were sutured and the case was completed. The surgery took about half an hour, but it's highly edited video, just showing it in 4 minutes. Thank you very much. Now we are open for discussion.
An excellent video, sir. A couple of things which I also do a couple of things like this. But do you do this routinely that you make a pars plana incision with the stab incision with an MVR knife? Or since you're a VR surgeon, wouldn't you prefer to have put a trocar there?
Yes, we can. That is another option. But if we put a trocar, it's difficult to close the wound. No. So I just use the MBA blade and I sutured the wound.
Actually, I do a lot of this, sir. It's one of my presentations in AIS also I've been doing for many years. So any comments? So Dr. Rajat Goyal, do you have, sir, any questions for Pradeep, sir, and any comments from your side?
Usually, if we find subluxation along with the PC rupture, so what would be like the first thing? Like we have to go with the pars plana route only, or we should look for the CTR and all. Usually, where a very accompanied subluxation is always there with the traumatic cataract sometimes. So, what would sir prefer to do if there is a subluxation also in this case?
If there is subluxation. What's the question? Can you repeat the question?
Yeah, if there is a dislocation or a subluxation of the lens accord with the traumatic cataract and the PC rupture, so how would we proceed usually with these cases?
Ideally, we should do antivitrectomy through pars plana. That is the first option. And when we know that there is subluxation and we know there is PC rupture in this case, as it is in this case, we should make a route first and then go into the anterior chamber. That is my way. That is how I do it.
But still, we'll go with the 3-piece in the sulcus only. The whole vitrectomy won't be needed. Like the proper PPV won't be required, because I had the same case, but I got stuck in between.
If there is subluxation, then whether you can place the lens in the sulcus or not depends on how much is the subluxation, how many clock hours. If it is only 2 clock hours, you may probably place the lens in the sulcus.
Okay.
But more than 2 clock hours, you have to think how to do it. If there is only subluxation and the posterior capsule is intact, you can use CTR and put the lens in the bag. If there is posterior capsule is intact.
Yes.
Posterior capsule is ruptured, and if you can convert it into a posterior rhexis, a round rhexis, then you can also place the lens in the bag. But in this case, it was not possible. We had to place the lens in the sulcus.
In the sulcus.
Yes.
Thank you.
Sir, I have one more question here for you. So a lot of these cases, what happens is sometimes there's fibrosis in the PC also, particularly if it's an old case. So the area of the rent has fibrosis. So why did you do a first anterior vitrectomy here? Why not start with the anterior approach and then go when you find something? And in that case, would you prefer to do visco-assisted aspiration rather than this? This made it easier because you're approaching from the behind. But for people with not your skill set, for beginner surgeons or intermediate surgeons, what would you recommend? What tips would you like to give to them?
What your skill set?
For surgeons who are having intermediate skills, they can go through anterior route, limbal route. In those cases, the cutter should go through the rent at least 3 to 4 millimeter behind the posterior capsular level, and from placing the port there, they should do antivitrectomy. The cutter should not be in the anterior chamber or in the bag, because then it will pull more vitreous.
So my question is not regarding the vitrectomy. I would like to tips regarding the cortex aspiration or the lens aspiration, because there's a big tendency for that to drop back, sir.
Yes, that's how I found the Simco very useful. You just go in the equator of the bag, be there in the equator and aspirate the cortex there with the Simco. Most of the time, you can the lens will not drop in the vitreous cavity. But if we use the cutter and aspiration and cutter, then the lens matter drop is more.
Sir, I have a question. Sir, if you are taking the cortex out with the Simco, the flow rate was through, like, it was fast, or did you kind of keep it at dry? How did you do it with the Simco, sir?
Not try, because try is not necessary, because already you have done vitrectomy, so it can be normal flow.
Okay. But the flow, you know, if you have a space where there's already a PCR, would that increase it with the excessive flow which you have, sir?
Yes, it can flow, it can increase if there is a rent during surgery. If it's during the normal routine phaco, if there is a rent, you do dry aspiration in those cases.
Yes, sir. Yes, sir. But here also you add the similar picture as a PCR only. So the Simco did not really cause any hamper or increase the size of the PCR or anything?
PCR, in this case, I didn't bother about increasing the PCR because I am going to place the lens in the
In the
sulcus.
sulcus. Okay, okay, yeah.
So one question.
I
What
noticed
was
that
the
you have
mode
used
of injury? There was no.
Hello.
Shashank sir, your voice is not clear.
You have to know what was the mode of injury. There is no posterior capsule substitution, only posterior capsule left. What was the mode of injury?
What was the mode of injury? I think you're asking.
This is a blunt trauma. It's a blunt trauma with PC rupture and sphincter tear.
So, sir, observed that you have used Simco for implantation of IOL. So, I think it's a very good idea because sometimes people use the irrigation from the irrigation and aspiration of phacoemulsification. So, in that case, sometimes the vitreous it gets hydrated and starts prolapsing more because it is coming under lots of pressure. So you use Simco for implantation of IOL. That was also a good idea, and that way we can prevent further prolapse of vitreous.
I wanted to add something like Dr. Karan said, is there any chance of dipping of the cortex inside the vitreous? So if you go through the pars plana route with the cutter, so that will prevent the cortex from dipping inside the vitreous only, because you cut the vitreous base first and then go on to the cortical matter. So it's basically the cut first and then the aspiration. So in that case, the chances of dipping of the cortical matter is very less.
You are just cutting the central part. You are not going to the equator of the bag. So dropping is less.
So that was a wonderful video, Dr. Pradeep, and we all already cherish your each and every presentation, and the same was with this one. Thank you so much for showing another very interesting case. Now we move on to next presentation by Dr. Aparajita Chaudhary. And we know, is director at MLN Medical College Ophthalmology Department of Prayagraj. And she will be presenting another interesting case. In fact, her senior resident, Dr. Sonam, would be presenting, and then the discussion would be taken on it.
Very good evening, everyone. Today we are discussing a very important topic which is clinically relevant as well as preventable one, that is steroid-induced glaucoma. What makes the steroid-induced glaucoma particularly important? That it is iatrogenic as well as preventable. The damage does not occur because the disease was aggressive, but because the monitoring was inadequate or the risk was underestimated. So on my behalf, my senior resident, Dr. Sonam Verma, will going to be present the case.
Good evening, everyone. I'm presenting the case of steroid-induced ocular morbidity in alopecia therapy. The patient was an 18-year-old male who was a known case of alopecia areata universalis and atopic dermatitis and was on long-term systemic and topical steroid therapy since 5 years for the same. He presented to us with chief complaints of gradual diminution of vision in both eyes and glare in both eyes since 6 months. For initial 1 month, patient was prescribed systemic drugs in the form of tablet methylprednisolone 16 mg twice weekly and tab immunib 5 mg twice daily. And topically, he was prescribed beclomethasone lotion on the alternate days and minoxidil 5% topical twice daily. After 1 month, he was kept on maintenance therapy with tablet prednisolone 40 mg twice weekly and tablet immunib 10 mg twice daily and also beclomethasone lotion topical application for alternate days. So in total, systemic and topical steroid therapy was given for approximately 5 years. This is a picture of the same patient showing patchy hair loss on the head known as ophiasis, and also there are no hair on eyebrows, eyelashes or cheek. On examination, unaided vision was 612 in both the eyes and best corrected visual acuity in both the eyes was 69 with minus 0.50 diameter cylinder in right eye and minus 0.50 diameter cylinder at 62 degree in left eyes. Intraocular pressure by non-contact tonometry was 29 millimeters of mercury in both the eyes and central cornea thickness was within normal limit in both the eyes. On slit lamp examination, orbit, ocular adnexy, ocular motility, sclera conjunctiva within normal limits. Anterior chamber showed open angles on gonioscopy with Schafer's grade 4. Lens had posterior subcapsular cataract of grade 1 in both the eyes and the fundus was within normal limit in both the eyes. This is the patient's cataract. On Humphrey's visual field analysis, the test parameters were normal and there were no significant focal visual field defects. This is the optical coherence tomography of the optic disc. Here we can see the RNFL thickness were within normal limits and optic disc parameters were within normal limit, except for the superior 1 clock hour in the right eye where the RNFL thickness was with below 5 percentile according to device's normative data. Patient was put on eye drop timolol 0.5% twice a day, and with that, patient was maintained at 17 millimeters of mercury intraocular pressure. And after that, he was planned for cataract extraction with PCL implantation in both the eyes and was advised for treatment to refer to the treatment dermatologist for alternate treatment options and also to regular monitoring of progression to steroid-induced glaucoma. So he was diagnosed with bilateral steroid-induced posterior subcapsular cataract and glaucoma in the background of alopecia areata universalis and atopic dermatitis on long-term corticosteroid therapy. Corticosteroids remain the most powerful and widely used anti-inflammatory and immunosuppressive agents in modern medicine, and they are indispensable in management of chronic inflammatory and autoimmune conditions such as atopic dermatitis, alopecia areata, asthma, connective tissue disorders, and various other diseases. And long-term systemic use is associated with significant systemic and ocular adverse effects like cataract, which is irreversible, and glaucoma or CSI, which can be reversible. So this case presents us with both diagnostic and therapeutic dilemma. Diagnostic dilemma arises because alopecia areata, atopic disease, and steroid therapy, they all individually can cause a risk of cataract. And therapeutically, steroids are essential to control these systemic diseases, but their continuation worsens the ocular complications. So stopping the steroid risks a systemic relapse while continuing it risks the permanent visual damage. With this, I conclude the discussion and open it for insights and remarks from the panelists. Thank you.
Thank you so much, Dr. Sonam. That was indeed a very interesting case. And I would like to have few words from Dr. Aparajita on this particular case.
This is a case which is quite difficult to manage because we don't know the etiology. As the patient is of the alopecia areata and it is a hereditary disease, it is somehow associated with a systemic inflammation. So this glaucoma is either due to the inflammatory glaucoma or it is a steroid-induced glaucoma. So we are unable to come to know about this etiology of the glaucoma. Since the patient is on the long-standing steroid, we keep the patient on the and the IOP was very much high. So we keep the patient on the timolol maleate, not on the latanoprost, because latanoprost can lead to further inflammation. So, this is my this suggestion is that there are so many ocular diseases which is causes the inflammation. So it is our responsibility to treat the disease, but also anticipate the complications too. Thank you.
So once steroids are being given, that will control the inflammation. So had it been an inflammatory glaucoma, the pressure would have come down after control of inflammation. So that can be one possibility. And how was the gonioscopy?
That was angle was open.
Open, and no signs of inflammation, any pigmentary changes, any synechias, any goniosynechias, anything.
No signs of inflammation is there.
No signs of inflammation. So most likely here it was steroid induced only, which led to this kind of problem. Any other comment from any other panelist? Any question?
What are the just one question? What other anti-glaucomas, like ma'am mentioned that latanoprost should not be given if we are suspecting. If it is a steroid-induced glaucoma, should we uh, think of that this anti-glaucoma should not be given or this has to be given if it we are proving that it's a steroid-induced glaucoma?
So, had it been an inflammatory glaucoma, as Dr. Aparajita rightly said, we avoid prostaglandin analogs. Also, pilocarpine is avoided in such patients because of increase in inflammation. This tall anti-glaucoma can be given comfortably. But because there are no signs of inflammation and it is a steroid-induced glaucoma, so here we can add other medications also. So if it is a inflammatory glaucoma, of course, prostaglandin and pilocarpine, they have to be avoided. But steroid-induced glaucoma, they respond to these drugs and therefore they can be comfortably given.
And after the surgery, did the IOP came back to normal or not? Like if sometimes I've seen many steroid-induced glaucoma patients, the steroids have been tapered down, and when after cataract surgery, usually the pressures come down. What happened in this case if it is operated or not?
Patient will operate for the cataract because as a patient has got a complaint of glare. He keep on complaining of patient is having the glare, although there was a grade 1 cataract. We will operate. It is planned for the surgery, not operated yet.
Another
Great.
thing you'll have is because you'll be having this, you have to give steroids post cataract surgery. So what would be your choice of
Yeah,
steroid? Would you prefer prednisolone or dexamethasone or loteprednol 1%? What some of the new some
this again
companies
has to
have
be.
come up with, and how long will you continue the anti-glaucoma medication? Because there is always a risk of again having a, steroid-induced IOP rise.
We will keep the patient for the observation, and I will just personally start with this methylprednisolone. On the for the topical medication, I will start the Deplozakot.
So deflazacort also causes quite a lot of IUP elevation. In fact, most of the steroids they do. So we have to be very careful whenever we are giving steroids in all such patients. We also have
Experience with the loteprednol 1% because they're the companies, some of the companies are promoting with the QID dose. What is the IOP effect of that? I have not used it personally
It's
for
very less.
cataract
It's very
cases.
less, sir.
yes. Yes,
It is very
IUP
good.
elevation is very less with loteprednol 1% also. So that is a very good drug in that way. But
And what
I'm
about
just
the
skeptical.
anti-inflammatory effect?
Yeah, that is what I was saying. I'm just skeptical about the anti-inflammatory effect, especially in immediate post-operative period.
Yes.
So that might not be equivalent to prednisolone and of course dexamethasone. So I'm slightly skeptical about it in starting in immediate post-operative period.
Then maybe you can do an RCT in the medical college. So
Right, right.
since you have access to that with close observation, you can do an RCT
Yeah,
So
definitely, definitely. I think it's a good idea. And we are having the company sponsored study is going to start. We already have ethics approval. So, of course, even though it is sponsored, but we will be very particular about the inflammatory effect of the drug, and we will see that how the drug is responding. So we have Dr. Pradeep Agrawal with us, who is fellow from LVPI and currently in Moradabad. Can we have a 2 minutes quick comment from him, Dr. Pradeep?
Good evening, everyone. Good evening, Dr. Salni.
Yeah.
So, for this case, I don't have any comment, but if you allow, then I want to ask something regarding
Yeah.
the previous case from Dr. Pradeep Monta.
Yes, yes, sure.
Sir, very nice surgery. Being the pediatric ophthalmologist, I have a lot of the cases of the pediatric cataract. They had pre-existing PC rent, like the posterior lenticonus. So I'm not the retina surgeon. So I usually go from the anterior route, keeping in mind that the because of the PC rupture, the cortical matter go inside the vitreous. But fortunately, it never happened. I think there is some vitreous coverage that is protecting. And most of the time, I'm keeping the IOP very low with the Centurion machine. Approximate it is 28 millimeter of the mercury. So most of the time, I'm comfortable removing the cortex, just leaving behind the PC rent. Sometimes the PC rent is in the circular manner. Just in that case, if the age is less than 10 years, then I do the vitrectomy. Otherwise, just I put the lens in the sulcus and come out. So, what is the negative points in your view if I am going in these cases from the anterior route?
In children, the even if the cortex drops into the vitreous cavity, it's a very soft cortex and it gets absorbed within 3 months, I think. What is your experience? How soon it gets absorbed?
Sir, we have the retina team also. If something like happen, then we usually call the retina person. They go to the pars plana and remove it. But I mean to say that most of the time it is not happening. Actually, you are the retina expert, and no doubt everybody knows about the that. But for the mediocre surgeon like me,
No, no, no. You're not a mediocre surgeon.
we are not thinking about the pars plana, and
Yeah.
especially in the children's.
In children, the vitreous is more, thick, like adults, the vitreous becomes more fluidic. And in children, probably the vitreous is giving some support and it is not allowing the cortex to drop. That is my thinking. Others may comment on this.
Although, sir, I am doing the adult cataract also, traumatic burn, similar case like you. Uh, but most of the time I'm keeping the IOP very low. With the help of the Centurion machine, you can titrate your IOP. And I keep the irrigation probe in the periphery, and I usually try to remove the cortex in one go. Once you are coming out from the irrigation probe, then because of the positive vitreous pressure, the PC can increase. And in fact, in these traumatic cases also, the if your IOP is moderate around 28 or 30 millimeter mercury, then the PC is also not increasing.
In the Centurion machine, are you using the cutter and irrigation itself for removing the cortex? Is it in IA first irrigation and then cut mode? Which mode you are aspirating or cutting, removing the cortex?
No, no. If the vitreous is there, then definitely first I have to do the vitrectomy.
Vitrectomy and
I
then
am I am talking about the only simple irrigation and the aspiration,
okay,
because in the starting I am not disturbing the vitreous phase
right.
to take out all the cortical matter first.
Okay, first
And
you are not disturbing the vitreous, you are just removing the cortex and then you are doing vitrectomy, is it?
yes, 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 yes.
It's fine. It's fine. See, vitreous, once you cut the vitreous, there is more chance of dropping the cortex. So if you can remove the cortex first and then do antivitrectomy, that is a better approach, I think. Then there is no chance of cortex being dropped into the vitreous cavity.
But yes, sir, same thing I am asking.
I think that is a prudent idea, as Dr. Pradeep said. And there can be multiple ways of handling or tackling a case by different surgeons. So I think that when the want of time, we move on to next presentation. I will request Dr. Karan to kindly call the next speaker.
So it's my pleasure to invite Dr. Lubhavni Devan, who is an MBBS, MS, and FS CEH cornea and refractive surgeon with 17 years of experience. She did a fellowship from Dr. Shroff Charity Eye Hospital, New Delhi, and is the director of Ananya Polyclinic, Delhi. She is the head of cornea refractive services at Ayurveda Hospital, Delhi as well. So she will be speaking about
Karan,
UBM videos. Yeah.
Karan, I think you've got the name wrong.
Yeah, I think
Lubhavni,
yeah,
that's me.
it,
That
I
was
just
my introduction you're giving, Karan.
Sorry.
Yeah.
Sorry, apologies. So I would introduce Dr. Lubhavni Devan for the to talk about UBM videos in difficult diagnosis of pediatric cataract masquerades.
Yeah, thank you, Dr. Karan, and thank you, Dr. Shalini, for the opportunity. I'm actually, I think, the junior most here. I don't have as much experience as everybody on the panel. I'll just quickly introduce myself. I did my MBBS from Maulana Azad Medical College and MS from RPC Ames. And my fellowship is in pediatric ophthalmology and strabismus and neuro ophthalmology from LVPEI. So right now I'm practicing at Shroff Charity Eye Hospital at Daryaganj in Delhi, and I'm also visiting the Saharanpur Center twice a month. So since the topic of the webinar is dilemma to decision, I just wanted to talk about some pediatric cataract masquerades where there was a diagnostic dilemma, and I'll be discussing a short series of 3 cases. Is my screen visible?
Yes, your screen is visible.
Okay,
We
okay.
can
This
see
is
the Zoom actually, a Zoom. So you've shared the entire thing as well. So you can go directly to the presentation.
I'll just
You can minimize the Zoom, or you can stop sharing and just go to the
I'll do
thing.
that. Yeah, new share.
Share again. Yes.
So
Yes.
this
We can
on
see your
right.
screen.
Yeah.
Yeah.
Okay.
Perfect.
Okay. Yeah. So I'll jump into the cases. This is a 7-year-old boy who came with a white reflex in the right eye with some history of recurrent redness, and it looked pretty much like a straightforward uveitic cataract. These are the clinical signs that we can see: some posterior synechiae, pigments on the anterior capsule. Just something suspicious was a slight bump in the inferior iris and some chamber shallowing in the inferior quadrant. The B scan was anechoic, apart from this finding of a stalk that is attached to the optic disc extending into the midvitreous cavity. So at this point, the differentials were obviously a uveitic cataract and a ciliary body mass because of the chamber asymmetry. So we were mindful and we did an ultrasound biomicroscopy where we saw this thickening, diffuse thickening of the ciliary body in the inferior quadrant. And this seems to have very well delineated margins and some cuff of fluid surrounding the thickening. So this was suspicious of an inflammatory pathology more than a malignant pathology like anterior RB or something else. So we went ahead with a cataract surgery. And once we see that the lens is aspirated and the view becomes clear, we will be able to appreciate the mass in the inferior quadrant. There is something like a stalk that is floating in the inferior vitreous, and there is a white epithelium lined mass that is the ciliary body thickening that we saw. So putting it all together, this was actually a case of a persistent hypoplastic primary vitreous which presented like a uveitic cataract with a ciliary body mass like appearance. This is another case of a 7-year-old girl who came with diminished vision and blurring of vision in the right eye with some history of joint pains. So again, we were suspecting a uveitic cataract. This was a posterior subcapsular sectoral kind of cataract in the nasal quadrant, and there was a slight band-shaped keratopathy, early BSK in the nasal and the temporal quadrants. The B scan was again anechoic, and we investigated her for uveitic profiles. It was all negative, and we did plan her for a lens aspiration under steroid cover. However, on table there was a surprise waiting. We saw there was a retrolental whitish mass in the nasal quadrant here. So again, we did a UBM, and we see this ring-like structure attached to the ciliary body with a hyperechoic structure within the ring, which is highly suspicious for a cystosarcosis cyst with some multiloculated septations also within the cyst. So at this point, the plan of management was changed from an anterior approach to a posterior approach, and we did a pars plana vitrectomy and lensectomy. Our retina colleagues did this surgery, and an excision biopsy of the cyst was done, which confirmed the suspicion of a cystosarcosis lesion. This is a third case of a 5-year-old boy who came with a whitish opacity which was gradually increasing in size in the left eye. There was no history of trauma or anything. And we can see this is a congested eye, and the lesion is very suspicious looking with keratinization, surface irregularities, some superficial vascularization. And if we see closely, there is some elevation and bumpy appearance of the iris in the superior quadrant and a displaced D-shaped pupil with a cataractus lens. So at this point, what we were thinking was that this could be a surface pathology like an ocular surface squamous neoplasia with invasion into the anterior chamber. And again, we did an ultrasound biomicroscopy. Now here we see that the lesion has different pathology. So inferiorly, there were some cyst-like lesions in between the iris and the lens surface. In the nasal quadrant, we see this huge mass that is filling up the entire angle, and we see some cystic spaces within the mass as well over here. And superiorly, again, there are some cysts. So this is actually very typical of a medulloepithelioma that presents typically around 5 years of age in children. And these ring-like lesions in with distorted iris anatomy, distorted anterior chamber anatomy is very typical of a medulloepithelioma, which unfortunately gets missed a lot of times and is misdiagnosed as some other lesion. So in all of these three cases, the UBM was what helped us in arriving at the proper diagnosis and guided the plan of management. So these are red flag signs in pediatric cataract that we must remember. And in all such cases which have anything out of the ordinary in unilateral presentations and absence of trauma, we should always think of doing an ultrasound biomicroscopy before touching the lens surgically. So that's all from my side. Thank you for the patient listening. We can open for discussion.
That was indeed a wonderful presentation, Dr. Lubhavni, and such interesting cases. Thank you so much for sharing with all of these to us. So we saw that UBM is very useful in many of the scenarios, although it is not available at many of the centers. But especially if you have to look behind the iris, then UBM is extremely useful, and ASOCT is not able to show all these lesions. But UBM is definitely, because of its ultrasonic technology, can penetrate the opaque media also, and is definitely very, very helpful. So we will have quick comments from few of the panelists.
Dr. Ivan, in the second case, your ultrasound was normal.
Yes, Dr. Pradeep, that is the cystosarcosis child, right? The second one.
Yes,
So
but
yes,
on the ultrasound, I think we can pick up that cystosarcosis, no?
so yes, we can, but the thing is that it's operator dependent, the ultrasound B scan. So if we specify specifically that we are looking for a particular quadrant and we are suspecting an anterior pathology close to the ciliary body, then I think we would have been able to pick it up. But it was done in a standard manner, and we were able to visualize more of the posterior pole, and somehow the lesion was missed on the B scan. But like Dr. Shalini said, that if there is a setting where UBM is not available and we are suspecting something like this, then I think it would be a good idea to specifically instruct whoever is doing the ultrasound, or do it yourself maybe, to look at the area of interest so that we don't miss such findings.
Yes.
So we have Dr. Surbhi Dutt with us, who is Cornea Fellow from Shaw Charity, New Delhi. So we will have few comments from her also.
Cases were uh, quite interesting, and especially the one which caught my eye was the cornea one, which you had shown in the end, and that was a really huge mass which was actually encroaching. So, how was it that even the cornea was involved? So, how did you take care of that part? What did you do? It was like a PK kind with the
No, so
posterior.
actually, once the diagnosis was confirmed to be a medulloepithelioma, we
Yeah.
advised for nucleation for this child since this is an invasive
Okay.
tumor and globe salvage is not generally possible in these cases.
That's what I was wondering. Yeah. Yeah.
Yeah.
So, that was planned and done, or did the patient's
Implant
parents have?
parents have not been we have not been able to convince them. They are lost to
So, it's
follow.
not been done yet.
Not been done yet.
It was very interesting.
We have Dr. Namrata Patel with us also, who is assistant professor in GSVM Medical College. And we will have a comment from her also, and then move on to next presentation. Dr. Namrata, are you there? Okay, I think she is not there. So any other comment? So I think they were amazing cases and very rare ones also. Thank you so much, Dr. Lubhavni.
Thank you.
And yeah,
I
can we?
have medulloepithelioma is supposed to be very malignant. So, do you look for metastasis also in the and is the scanning essential for the entire body, like body scan for any metastasis and all?
Yes, Dr. Upasni.
Because
So
it is
whatever
one of the most malignant tumors.
from what I read, I think it is more of a local extension that occurs before metastasis. It's locally invasive. I have not read about any case which presented with a metastasis as such. For this particular child, we did not advise a PET scan, and unfortunately, the parents were not keen on surgery also, so we have not been able to follow up the child. Yeah, and I'm yet to come across any other case, similar case. We had a similar, very early presentation of medulloepithelioma. That one was also picked up on UBM. So that was a relatively earlier presentation. The child did not have any other systemic features.
Okay.
Thank you.
Thank you.
Thank you. So now we have Dr. Nilesh Kumar with us. We know he is secretary of UC and very active academically. Wonderful surgeon from Ara, Bihar. Dr. Nilesh, we would like to see your presentation on runoff Rexus and PCR handling a premium IOL.
Thank you so much, ma'am. And it's my privilege to present in front of Pradeep Mohanta sir. He has been my virtual guru, both me and my father. It's like two generation he has trained. And I'm just going to share my screen. This is one case that I came across. It was the first trifocal IOL I was going to implant of Zeiss. It is Zeiss Ilana. And for the I'll just restart it once again. So it is a mature intumescent cataract, and I usually do capsular massage to prevent runoff, but somehow I didn't do that. Was my first mistake. And then I just put a nick and tried to complete it with that open margin that was there, and the patient was having he was very conscious, and the iris prolapse was happening. So what I did is just cortical shaving, and when I'm just doing the heminucleus thing, I just noticed that from that area the rexus has run off behind posteriorly, and there is a big PC rent that is there. But luckily the edges of the PCR were not rolled up, and there was no flail sign that was seeing. The flutter sign was negative as described by Rohitam Prakash sir. So I thought that it is the vitreous phase is intact, so let me try to put it in the bag as IOL scaffold, as well as it will give me support that no pieces go behind. So I am using the same trifocal IOL. What I am trying to do and make sure is that my second instrument is keeping the lens behind, so I don't go and hit on any of these rings, or in the on the front surface where there might become a dent, and it'll uh, do the trifocality will go off. So now I put a suture, and so that the prolapse goes off. And as you can see, there is a little bit of cortical matter behind. So I thought that let me leave it, and later I'll do a yak capsulotomy and tackled that. But then I thought, okay, let me check if it is the posterior surface is special. Let me gently aspirate it. So I just lowered the bottle height and I tried to go behind. The IOL. I was not able to go behind from my non-dominant hand, that is my left hand. So I'll just try to go with the irrigation probe and try to move it from that side. I can go. So now I switch my hand. Now my dominant hand is having the probe, and now I am just gently pulling out that cortical matter and doing it. So the patient ultimately, the lens was very stable. The patient is now 3 months into follow-up, and I have done the other eye with the same trifocal, and the patient is bilaterally and unilaterally also reading 6 and 6. So if the crux of the matter is that if posterior surface is not disturbed, and if we try to try to do too much of manipulation and get into vitrectomy where the vitreous phase is not disturbed, it might give us adverse outcome. Sometimes doing minimal thing gives you better outcome. So similar case, one I think Dr. Pradeep also was asking about one case. So I'm sharing a case where it is a pediatric traumatic cataract, a young boy of 17 years and a pre-existing rent that is there, a big rent that is. And luckily for unlucky for me for this case also, it was a EDOF that he has chosen from Zeiss, that is 80 Lara. So what I did is beforehand only I was very prepared that let me not do anything and be prepared for vitrectomy. So meanwhile I am doing the visco separation. My attendant has already primed the machine for vitrectomy, so that if we go into that, we don't waste any time and we are ready for any eventuality. Now we stay in the central safe zone. So both videos you can notice that it is the main thing is that the phaco probe was not moving from the central area. So in this case also we are staying in that central safe zone and using the second instrument to bring everything to the center and aspirate it. And now I'm just going and trying to be very gentle to pull the epinucleus in the center and then aspirate rather than doing anything there. And once I see that there is a cleave that is available, now I go from my left hand with a viscodispersive agent and put it over the rent so that it goes and coats the pre-existing rent. Now with the main port, again I go and fill it up more so that there is a good nice covering on that. You can see it is very nice. And again, when I noticed on my microscope, the flutter was not there. This video is obviously sped up, so we are not noticing that. But when I was doing it very slowly, I could see that the margins were not fluttering. So again, it was a sign of intact posterior hyoid phase and sorry, intact anterior halide phase. And so I just moved ahead and did a gentle low thing aspiration. Before taking out, I do a visco exchange and now take out the remaining cortex. And again, because the vitreous phase is not disturbed, we can do a in bag implantation. So we don't try any visco implantation in this. Try a hydro implantation. The patient is 6'6" in 10 right now because it is an EDOF lens, very good intermediate vision he has got. So with this, I hydrate the main wound so that there is less turbulence, and then do a gentle IA wash. So even we were ready for vitrectomy, but sometimes we don't need it if we are very careful and don't disturb the vitreous phase and the phaco-dynamics are in control. So with this, the case is almost complete. But whenever I am removing anything in such cases, after visco removal, what happens when we take out the irrigation, the AC collapses and the vitreous starts coming in. So I always do a fluid air exchange in the AC before taking out, so that there is the AC doesn't collapse. Now a little bit of pyrocarpine and again hydro, so that a tight chamber is there, and then the case gets closed. So with that, I'll stop my presentation and I'm open for any discussion that is there.
Nilesh, very nice presentations, very nicely managed cases. My suggestion will be try to not questions so that the Rexis doesn't run out. Okay, rather than managing it well after it runs out. So take more precaution and focus on good Rexis without intact Rexis, rather than taking have it let it happen and do it very nicely. So my
Yes,
suggestion
sir.
is that.
Yes, sir. Yes, sir. Completely noted, sir. After that, I am very careful with these intermittent cataract, and whenever it is required, I would just do a baby rexus and then do a two-step rexus.
Very well managed, Nilesh. Some difficult scenarios, particularly when you're in private practice, it gets difficult, and these premium lenses are the ones that sometimes are the ones with the more complications than the simple ones. I had a recent panoptics also. Other eye that I did during PC polishing, I had a PCR, but I implanted the IOL, and patient is doing well. Minimal manipulation is actually the key in these situations, and I'm sure Dr. Mohanta and all the experts over here would agree. Any questions apart from the panelists here?
I have a question. In your first case, how about using the pupil? Because I saw your pupil was contracting. It was getting myosed in the mid of the surgery, in the middle of the surgery only. So if you use a pupil expansion device, first thing is you could have seen properly. The rexus runout could have been seen and managed before doing anything. Second, you started having iris prolapse from the main port also towards the end of the surgery. So both the things could have been managed with a pupil expansion device if it would have been put in the first place only.
Ma'am, I thought of using, but with IFIS, it was a case like there was from the first time only there was an iris prolapse. The patient was also having a bit of vitreous thrust. So whenever I use iris, because there are only two options right now. One is the classic iris hook, and now B Octa is there, which gives which prevents the iris prolapse actually. Other pupil expansion devices don't prevent the iris prolapse. With the iris hook, it actually tends up, and it creates a less space. Already it is a intermittent cataract with a very shallow AC, so I was not willing to go with an iris hook because it will create less space. And with B Octa again, it was a very big device, ma'am, so I thought that let me try. I just thought that if I am going to use the reverse pupillary block and expand, it was with reverse pupillary block, it was giving a good mydriasis, so I was trying to use that and not do any device.
One tip, if you will allow me, Nilesh, is what I would do is, if the first time the prolapse happens, the first time is when I come out with my, if I try to put it in, if it's in a side port, I would put it with my chopper, push it inside at the same time. Otherwise, shaffing will take place. Like in your case, a hole
Yeah.
was created there. So come out, put some dispersive OVD to push the iris down. So that has an effect, because the more and more times you handle the iris, what is going to happen is shaffing, hole, and these actually things can not might not alter the outcome that much, but it can what it can do is it can give a cosmetically not good look for you, particularly not with the patient that much. I
Patient also, this patient also said there was a little bit of glare because of that hole that is there. So because it is a trifocal level, patient was having a little bit of glare. But this is a late learning that came to me when I saw the video. Meanwhile, one more case of iris prolapse where I did the same thing and there was a hole created, and then I went back and saw these two videos. And I think we have discussed this offline also. And this viscodispersive thing I have started using now. So no, any of the cases that iris prolapse is there, I put a nice visco dispersive coating everywhere, and then proceed with the case.
Face is always a challenge. So the thing is with I've had in a panoptics where the entire iris I've eaten. So you need to be very careful with iFace.
Yeah. So you went on mute.
Any other tips, Dr. Mohanta, would you like to give for iFace cases? Any tips for iFace cases to so that you don't eat the iris? Any, and the panelists can also come in, please.
Yes. So that the iris doesn't prolapse, is it?
So that you don't eat the iris with the phacoprobe. That's the main thing with IFIS, because first the settings, that how would you would reduce, you would use a second instrument or any other device so that you don't eat the iris with the phacoprobe, because it can happen with IFIS.
IFIS, the sure shot so that you don't injure the iris is to use B Octa device. B Octa. Okay. So if you use that device, It dilates the pupil to about 6.5 millimeter, and it will be more than enough. You know. Can you hear me?
Yes, sir. Yes, sir.
And next thing is, if you chop the nucleus into pieces and then do single-handed phaco, don't use the side port. And then also you can be in the middle and let the pieces come to you. Then also you can do it nicely without touching the iris.
Putting
I
a bolus
think,
of visco just near the prolapse also helps.
Yes.
Dr. Mukesh sir
Shalini
has
ma'am, are you
some
there?
comments in the chat box, sir.
Yes, yes, yes. So that was wonderful cases shown by Dr. Nilesh. And so many a times optic capture is another option which can be tried. So when do you advocate optic capture in these patients?
Ma'am, I usually do not try to do optic capture with the single piece IULs. If it is to has to be IUL capture like optic capture, it is a three-piece IUL that I switched to. So that was a backup plan, ma'am. So if this was going south and if I was not able to implant in back, then next thing was I was going to implant a three-piece IUL and tell the patient that there was a complication and we were not able to implant trifocal. So that is the only tip, ma'am. If it is these lenses should not be, because these are premium patient, and if they constantly get uveitis because of the trifocal in sulcus, it becomes a very difficult situation.
Right. Dr. Mohanta, would you like to add few things about optic capture? Dr. Karan?
Yes, ma'am, I agree with what Nilesh has said, that optic capture should be done only with a three-piece lens, and a single-piece lens is what is intended only for the back and not for the sulcus.
Right. So any other panelist would like to say anything? So with this, I think we have come to an end of this webinar, which showcase wonderful cases. And the best part is today we finished on time also. Otherwise, every time we used to extend. So thank you all the presenters who stuck to the time, and that is why we could finish this on time. And thank you all the panelists for the amazing discussion, which actually was beneficial for each and every one. And I am pretty sure that all the attendees would definitely take away some good take home messages after this webinar. Thank you so much. Thank you, everyone.
Ma'am, our president has joined us, Dr. Shashank Kumar sir. So any words from you, sir, before we conclude the webinar?
Dr. Shashank, sir.
Thank you, Dr. Karan, Dr. Shali. Well conducted and very informative webinar. And I think most our members who are in this webinar, they will be benefited. And I hope such type of webinar we should continue in future. Thank you, Dr. Karan, Dr. Shalini. Thank you. And thank you to all speakers and the members who attended the webinar. Thank you. Thank you. Good night.
Thank you, Shashank sir. And in fact, this idea is primarily idea of Dr. Shashank sir. He only advocated that we should go purely for video-based presentation so that it is actually educating each and every one of us. Thank you, sir. Thank you all the speakers and thank you all the expert panel. Okay, good night.
Thank you, ma'am. Thank you, sir.
And
Thank
of
you.
course,
Good night.
thank you the
Thank you. Good
IT
night.
team
Good night. Good night.
who is managing this webinar for all of us. Thank you so much.
Best wishes for you.
Thank you. Thank you,
Thank you.
sir.
Thank you. Good night.
Thank
Thank
you.
you. Thank you so much, everyone. Thanks a lot. Good
Good
night.
night. Good night. Good night. Good night.